This original WSRE presentation is made possible by viewers like you. Thank you.
Men's Health, how to keep ourselves in top physical and mental condition on this edition of inStudio. It's no secret men are not necessarily fans of going to the doctor. We commonly will tough it out or rationalize with ourselves that it's nothing to worry about. Fact is, we need to take better care of ourselves. On this edition of inStudio, we'll discuss the importance of taking care of both our mental and physical health. Our guests have a wealth of medical experience and expertise from a variety of medical specialties. Dr. Mark Ryan focuses on primary care and is a specialist in internal medicine. Dr. Ryan holds both an MD and MBA. He has presented nationally and internationally on treating hypertension in primary care settings. Dr. Ryan is with Woodlands Medical Specialist in Pensacola. Dr. Rick Spencer is a psychologist and partner with Psychological Associates in Pensacola. Dr. Spencer has doctorates in both clinical and developmental psychology. He specializes in child, adolescent, adult, and forensic psychology. Dr. Kevin Welch is a board-certified dermatologist with over 3 decades of experience. He is with Welch Skin Care Center in Pensacola. Dr. Welch specializes in cosmetic dermatology. Dr. Brett Para is a urologist with Woodlands Medical in Pensacola. He specializes in minimally invasive and robotic surgery using the Da Vinci robotic system. Dr. Para has been in practice for over a decade and is a board-certified urologist. Well, doctors, welcome and thank you so very much. So,
Thank you for having us.
First question, and let me begin with you, Dr. Ryan. Why is it that men don't like to go to the doctor?
You know, that's a very good question. I think I tend to use the analogy of taking care of a car. And so you kind of have like 2 groups of people. There are some people who go early for their oil check. Every 3 months or every 2,000 miles, they're in there right on time, getting everything taken care of. And then there's the group that kind of there are a number of priorities that kind of overrun general health maintenance and they delay. I think one of the bigger issues that I'm sure everybody sees is the cost to patients. Over the past couple of years, particularly in commercial insurance plans, there's been a lot more patient responsibility for the cost of seeing healthcare. And so it's a question of the time it takes to leave work to go see the doctor, the cost that's going to be associated with that, and then the benefit that they see out of seeing anyone that they go seek care for. So those are the things that I run into. I think from my perspective, at least on a preventive side, most commercial and even Medicare plans, at least once a year, you should have a free annual visit where you're able to go see a physician, a primary care physician, and to at least have your blood pressure checked and be up to date on all of the preventive screenings that you should do to keep yourself, in using the car analogy, going to 200,000 miles.
Well, as a psychologist, let me ask you, what's going on in men's minds that kind of keeps them away from the doctor's office?
Well, I can certainly talk about how they stay away from the mental health field. Because if you look at the numbers, there's only about 1/3 of the patients are men. So, we think there's that cultural aspect that you always have to be tough and kind of hold strong and not show your feelings. So that still is probably the pervasive cultural aspect that probably prevents them from just reaching out for help. And when I see typically for men, it's someone else recommending that they go. It could be a marriage issue, or they decide that they have an anger problem.
Right.
Often depression in men looks more like anger because they begin to hold in and they externalize that and become angry in ways that are not common for their relationships. So I'll have wives that send their husbands to see me. So that's typically how they come in. Or maybe more relationship-wise. But I think there's still this cultural divide a little bit with men, and that probably is a reason why they may come blessed to see a primary care physician as well.
Do you see, particularly with the mental health aspect, there's also, I think generally still a stigma, unfortunately, about seeking mental health care. Have you seen that decrease over the past several years, or is there still?
No, I think it's decreased. I've been in practice in Pensacola for this August 31 years, and so it's been a while. And I definitely have seen
Very
it
good.
decrease over time, and especially with children too. I mean, I see teens have totally different points of view on how they see the world as opposed to when I was growing up. So I think there's some good things going on.
Yeah.
But there is still a little bit more hesitancy.
I think from my perspective, when the wife tells the husband to come in, you have an anger problem, and it comes to the point where the wife is telling, you're in the office saying, you've got to address the anger problem or we're going to separate.
Right.
And I think it's difficult to even kind of to not pass that off to a psychologist or psychiatrist, but to kind of make the diagnosis of maybe this is depression, you should seek some help. There's a definite reluctance to seek out mental health care. Mm-hmm. And I think, and a lot of it probably is more than probably cultural in terms of the man trying to be strong and having to assume everything, right, and not necessarily a stigma.
In your case, Dr. Welch, I mean, we live here in Florida. It's the Sunshine State. We probably ought to be coming to see you, at least once a year?
Kind of probably. Men are a little less hesitant to come even in for dermatology. I bet you we can all relate a little bit to the fact that we're all supposed to be rough, tough, supportive. We're responsible for our families to some extent, and things are changing in that regard, of course. But I think a lot of men feel still that traditional role, and things are shifting. But a lot of men have that traditional mindset. But one of the things about skin is you can't necessarily see your prostate or your liver or your brain, but your skin you can kind of look at. So sometimes guys will come in because, Doc, I got this spot on my hand or my back. Although one interesting thing, of course, is that it's very common for men to come in and say, gee, my wife says there's a spot on my back that you got to look at. And so you would think there'd be a lot of women coming in saying, gee, my husband says there's a spot on my back I have to look at.
No.
Almost never. So I think women are paying more attention to their spouses, at least in that way, than men are paying attention to their spouses.
Right.
So.
And in your case, Dr. Pear, I mean, that's...
Well, yeah, that's what I do. I'm men's health, I'm urology, but the reality of this is men and women are wired different. Men are reactive. Men fix problems. When it's broken, you fix it. Yeah. If it's not broken, why fix it? And that's what I see. And what's been fascinating to me is I've been on the forefront with prostate cancer and screening, and of course there's been lots of dilemmas through screening, what you should do and whether primary care should. But what's been fascinating is how I've gotten men to come in. It's very rare that I'll get a man to come in that says, I just want to get my prostate checked. I don't see that very often, okay? Yeah. What I see though is, I've made this comment before, it's kind of maybe a little bit off cuff, but I think Viagra has saved a lot of lives. And people are like, what are you talking about? I mean, Viagra, of course, is not for prostate, but what happens then, a man will seek care for sexual health and erectile dysfunction, and while he's there, what I'll always do is I'll do an exam and I'll check his PSA. And I have countless episodes of patients that were coming in for that reason because something wasn't working properly, and it leads you to find something far greater and can save the life. Mm-hmm. I mean, how many times do we do imaging and you're looking for a gallbladder or whatever, and all of a sudden there's a renal mass? Yeah, the so-called incidentaloma, we see it all the time. Mm-hmm. But the question is, how do we change the mindset and get men to come in? And where I found it fascinating is quite commonly women drive it. Mm-hmm. So often I'll get a man to come in because the woman says, look, you need to go there. My wife complains about my snoring, so hey, I'm going to go see the doc because I need to get that checked out. Because when mama's not happy, nobody's happy, and I got to keep her happy. So I think women drive healthcare more so.
Yeah, that makes a lot of sense. I know. I read, I believe, a blog you had written that said something in the ballpark of 100,000 lives a year could be saved just by health screenings.
Yeah. To the point that Dr. Perry just mentioned. Yeah. These are not expensive tests. A PSA, a digital rectal exam. Even colon cancer screening, I can't tell you how many patients that come in as a new patient, and they're complaining of shortness of breath or fatigue, and you do a routine blood test, and you see that they're severely anemic in their mid-50s, had never been screened for colon cancer. There's definitely opportunities to intervene earlier and prevent a lot of preventable deaths.
But look at our community. Look at the newspaper. I mean, how often? Bras across the bridge. Save the tatas. Show me a jock straps across the bridge.
Yeah.
Right. Show me a save the boys.
Right.
We don't do it. No. Men just are not advocates for their health. We're just not. Right. So,
an example. Kevin actually treated me for a skin cancer, and it was my wife that got me to go. Right. And I need to come back. Hadn't come back in a couple of years, and I'm thinking, okay, it's about time.
It's hard. You're busy.
Right.
You know,
Every excuse
We're
you can have.
doing the male
Exactly.
thing. We're kind of getting
Yep.
out there and working hard.
If
and-
it's broken, we'll fix it.
exactly.
Yeah.
But
When it's broken.
preventative health is the challenge. It really is.
But I think what I'm hearing you guys say is these small little things can be fixed easily in the beginning, but in the case of a skin cancer, it could get out of hand. I mean,
melanoma, for instance, which is the bad kind of skin cancer, you catch it early, it's very treatable. You catch it late, it's very difficult, and it takes maybe a 5-minute exam just to look. And especially in Florida, we have a very high rate of melanoma as compared to northern states because of all the sun, and it really behooves people to get checked by someone at least once a year. And it literally is a life-saving thing. And melanoma is also one of those things, I think a lot of times men will start embracing it a little bit more as they get older because they see a primary care physician and they finally get enrolled in a system. Yeah. And it's like, Mr. Smith, you got to do this, you got to do this, you got to do this. But younger men, like you guys, younger men, we still think we're strong and healthy and vital, and we don't need to do all that stuff. And melanoma, for instance, is a thing that affects younger men. So you don't get those guys or women to some extent in when they're younger because they don't think they need it.
It really is, yeah.
so like when you're doing a wellness visit, might you see something that you just say, man, I'm a little uncomfortable with that spot or something, you need to go see Dr. Welch?
Yeah, without a doubt. I think there have been a number of studies that have been published about, more so within the dermatology community, who has the expertise to determine skin cancer versus not skin cancer. And without a doubt, I don't have the expertise to determine skin cancer versus no skin cancer. So if someone comes to me, and it's usually someone that says, my wife, at the end of the visit, my wife wants to just check out the spot here and see what you think. I will look at them and say, you need to see a dermatologist.
I think it's great to get somebody looking.
Exactly.
It's great if you're looking. I mean, that's great, though. I mean, you're looking.
And I think
it's great.
to your point about kind of most patients wouldn't necessarily. It's easy if they're there for the physical. You can get everything taken care of, and they wouldn't necessarily. They don't know who to call. They've never been to a dermatologist. They can ask a friend, but having the kind of the referral to this is who will take care of your problem is really what my role is in that situation.
I've got a question.
Sure.
Is it harder to give a mental health referral than a skin cancer referral?
Yes.
Yeah.
Yeah.
Okay.
It
And
is.
that's important because that gets back into the stigma that exists even
yeah.
with us.
Yeah.
Or to convince the patient to go seek it. I mean,
Right.
you can identify it and say you should do it, but to convince them to want to do it, absolutely.
Right.
And I think it's difficult to even. It's easy to say, to your point, this is abnormal. This could be melanoma. I can't make that determination to go see a dermatologist. Where there's a lot of, and from my perspective and the patient's perspective, some subjectivity in saying, you have a mental illness. You should seek psychiatric care. And I
have to put it quite that way.
This is true, but I think, but at the same time,
he didn't want to do it because he didn't want it in his medical record.
He didn't want to medical record.
Oh,
Yeah, sure.
absolutely.
Yeah.
True. I've definitely heard that too, and I've had people come outside their medical record
And
to
if
do
People
that.
change their name sometimes, or I'm aware of that. People will go and my name's Joe Smith, but I have this problem, and I'll pay cash because I don't want my insurance involved.
Right.
And even to take the medication. I mean, it's one thing to even have it in medical record, but then to make the next step, which is, okay, if you don't want to see a psychiatrist, well, then you should probably take a medication. And that is, again, just a big thing that there's a big resistance to having that documented somewhere.
What if it's more resistance to take the medication or to go see a counselor? I would think the medication might be a little easier because it's more of a quick fix.
Yeah, I think so. And unfortunately, I think most of the time it's not necessarily a medication. They don't necessarily need a medication. The longer term fix would be to see a counselor.
Right.
And
mild and moderate depression
Yeah.
are just as effective with psychotherapy as any kind of medication.
Yeah.
I want to continue this discussion on mental health when we come back. We're having a fascinating discussion about men's health, both physical and mental. We hope you'll stay with us. You're watching In Studio on WSRE Television, PBS for the Gulf Coast. We're coming back in just a couple of moments.
When you are with WSRE and PBS, you know there's always something amazing coming up next. It's a special commitment to sharing the world and our community. It is an irreplaceable service in communities all across America. The fact is, television that has the power to share the world also has real costs. These costs are largely funded by people like you and me stepping up generously to make sure WSRE continues to thrive. So please stand up now for your cherished values of curiosity, openness, and excellence with your vital donation to WSRE. Give now to make sure that the best in news, culture, science, history, drama, and children's educational programs stay strong right where they belong, right here on WSRE. Thank you.
Welcome back. This is inStudio on WSRE Television, PBS for the Gulf Coast. Our topic, men's health, keeping ourselves in great physical and mental condition. Our guests are Doctors Mark Ryan, Rick Spencer, Brett Para, and Kevin Welch. Dr. Spencer, we were talking about mental health as we went to break. Anecdotally, it seems to me like there are an awful lot of middle-aged men who take their own lives.
Well, it's true. If you look at the percentage of suicide, 75% are men. That's a lot. So we think a lot of that number has to do with the PTSD, a lot of veterans, but as people become older and become more infirm, they're more likely to take their life too. So, but also we go back to the idea that if men are withholding and not going and seeking treatment, then maybe they're internalizing that depression more and not reaching out and think that suicide is the solution. That's when you become hopeless. And we want to facilitate hope and recognize that those are treatable conditions.
It seems to me like oftentimes, or sometimes I should say, that you will see somebody and on the surface it looks like they have everything. Looks like they have a great family, plenty of money and things like that, and it just happens out of left field. What drives that? How do you identify something that may be wrong with that person?
Well, you hope that the family would identify that, because the people that are closest to that person would recognize there are some other signs that are really off. As you just said, that example of the person is not showing the community that.
Right.
They're out there living their life, look like they're having a wonderful time, they're winning, but in reality, they're not. And the spouse, maybe even the children, are going to recognize some of those signs. Maybe it's restlessness, having sleep difficulties, irritability, things that are just changing in this person's life. And that's usually going to be associated with some life stress, financial stress, parenting stress, various life changes that are going on in their lives that only the family would know about. So they really have to watch and then facilitate, hopefully, some type of help.
Is it easy for you guys, and easy may not be the correct word, but I mean, Dr. Ryan kind of mentioned, sometimes you see somebody may have, is it easy for you to pick up on maybe there's more here than what's meeting the eye, even if they're not necessarily there to see you about, maybe they're there to see you about skin cancer or something, but is it easy for you to pick up? I mean,
it depends. You can always identify the problem, what they come in for. They have a chief complaint. So what are you here for? Well, I'm here because my stream's weak or something like that. Well, you can get into that, but certain things kind of lead you to maybe want to drive into to go further, because again, men are not proactive in pushing their own health care. So for us, what's really hard for me is the disease prostate cancer that I deal a lot with. Right. It's really asymptomatic until it's way advanced. So it's a lot like breast cancer. A woman doesn't hurt or suffer from her breast cancer until it's basically too late in most cases. So with that being the case, we're trying to convince guys that you need to do something to potentially fix a problem that you don't even think you have and you may never get. And so it's a little bit of a hard sell. There's a dilemma there, but what you hopefully can do is you can kind of talk to the person, examine them, and men a lot of times respond out of fear. One of the things that have driven patients to me many times is they had a brother, a cousin, a minister, an uncle, and my uncle died of prostate cancer. Well, all of a sudden they'll come in and they'll be driven for that. And that's where you can kind of maybe capitalize on it and use that as an advantage to maybe convince the patient to get further evaluated. But it's a challenge. It's a challenge with men to be more proactive.
How old should you be when you start really paying close attention?
It depends. Years ago, the recommendation was that 40, 50, that whole recommendations for screening, there's been a lot of information. There's an organization called the USPTF, which went through and evaluated the famous test PSA and said, is it valid, is it not? And they gave it a downgrade. There was some faulty, flawed data there, and it's now been revised. And so what the current recommendation is from our AUA guidelines is that anyone with a family history, anyone African American, anyone that fits a high risk category should begin discussing screening with their physician at age 40. Then beyond that, routine men that have at least a 15-year life expectancy. So 50 to 60, but definitely 60 to about 70 are in the high risk zone. The debate comes in beyond 70, should you be screened? For so many years, we did these prostate cancer men's health screenings, and who showed up were 86-year-old men who'd already had 2 PSAs, didn't need another one, and they wanted to come talk about Viagra and Cialis. Well, that's not it's not a very good screening.
That's awesome.
Well, we did one, though. We did one in an African-American church one time where the minister himself had prostate cancer, suffered and died, and it's a high-risk category, and all of a sudden we diagnosed multiple prostate cancers. So it's really who should be. And then the other misconstrued that people don't get is that people assume that if they go get screened and if they have a high PSA, that by definition they have to have a biopsy. And then they assume that if they have a biopsy in prostate cancer, they have to be treated. And they assume that if they get treated, they're going to have complications and have issues of incontinence and ED. That's not necessarily true. What we were not so good at for so many years is we saw a nail and we hit it with a hammer. The man had prostate cancer, you treat it. That has totally shifted and changed. I have a large percentage of patients that I'm doing what's called active surveillance and watching them. They have non-aggressive cancer. It may never be a problem, and we're monitoring those patients very closely. I don't know that we've figured it out completely, but I think we're getting much better at discerning who needs treatment and who doesn't. And we weigh it based on how long they'll live, how healthy they are, life expectancy, but then also whether they have symptoms or not and how aggressive the disease is. The younger, more aggressive, needs to be treated. Older, not so aggressive, you may want to watch it. So just to get screened doesn't mean that you're putting yourself up and setting yourself up for those issues that men, are with.
And when we're dealing with chronic illness like that,
Same
active
thing.
surveillance, we're dealing with a lot of anxiety.
Absolutely.
And corresponding mental conditions just because of the chronic
It's
condition.
a lot harder to talk someone into non-treatment than it is treatment,
Right.
even if they don't need it.
You know,
Right.
it sort of brings up a societal issue in general that we spend so much of our healthcare dollars at the end of life.
Right.
And I understand it if it's my father or if it's me, please come to, But having said that, active surveillance for a 85-year-old guy, probably what you would want, what I would want, and what he needs,
Right.
And skin cancers, I run into in skin cancers. I see situations where some dermatologists are taking basal cells off an ear of an 87-year-old guy who's very ill. I understand why they're doing it, but I just don't think it serves any purpose for the patient or for the greater overall society, Yeah. I mean, I think we really have to address that societally at some point. That's beyond the scope of this conversation, but you guys understand what I'm saying, I think.
Definitely.
No, I think that's a very valid point. Going back on the prostate, are there some types of cancer, as I understand it, prostate cancer, that you can basically live with for your entire life, and it's not
Absolutely.
aggressive?
There's the old saying that if you live long enough, you get prostate cancer, and that's not 100% true. But if you take autopsy series of patients over age 85, you're going to see well over 60% of those men will have an occult prostate cancer. But it may be a minuscule microscopic one that would never be a problem. So what we do is we risk stratify, in essence. The younger the man is, the healthier he is, the more aggressive we want to screen and watch those patients. The older he is, the less symptomatic, there's an issue. But what we've seen is there's been, if anything, our testing efforts were too good. PSA was too good of a test. It was so good that we found a lot of prostate cancers that we never really wanted to find. We found occult ones that would not harm a patient, that they would die with and not from. We treated those, and we're a victim of our own success. If you look at the graphs that show prostate cancer prevalence, it shot up dramatically in the early 80s, because that's when PSA came out. Also, deaths from prostate cancer ratcheted way down. It got to where it was very rare we ever saw a man die from prostate cancer. The curve's shifting back. And the curve's shifting back because PSA has been downregulated. A rectal exam is something no man wants. It's something you talk about it, they get squeamish. No, people don't want to. A PSA test, a blood test, and I would argue that the PSA test, especially in a non-trained hands, primary care doesn't do it all day long, is definitely more sensitive at picking things up than what the digital rectal exam would be. But now that we've gotten so many men not getting it, now what I'm doing is I'm seeing a lot of guys, they used to see guys with PSA elevations from primaries that were 4.5. I'm getting 26 because it's not until they begin to have symptoms or have problems or that they get an exam and it's just beyond abnormal. And at that point, they're not as fixable. So how do we shift it back? And if we shift it back, we need to do, the one thing that has good come from this is we've learned. We've learned that we don't need to treat all these patients and that we should risk stratify, have a discussion with the patient. And because of that, I think we're getting a lot better at balancing it, but now we need to get back to getting especially those high-risk men in, because to screen, people aren't worried about their mortality until they face their mortality. Right. So the 85-year-old guy wants to be screened. I don't want to find prostate cancer in the 85-year-old. I'm not going to help him. Yeah. When I diagnose prostate cancer in 85, I've got to spend an hour with that guy trying to explain to him why I'm not going to treat him, and he begs to be treated. The 44-year-old guy, I need to treat that guy. Mm-hmm. I can make a huge impact and save his life. So it's trying to get that message out. That's why this show is fantastic. I hope people watch it and take it to heart.
What are some of the high-risk symptoms of prostate cancer? In other words, what puts you in a high-risk category?
As far as patients high risk, family history is huge. African American, but beyond that, really, unfortunately, until prostate cancer often spreads outwards. It's on the outer part of the gland. So really, by the time it causes symptoms, it's usually pretty far gone. So really, symptoms there's not. Mm-hmm. So it's just, and it's simple. If you're going to see your primary, it's a simple blood test.
You know, and I think one of to piggyback off what you were saying, I tell patients when we're talking about cancer screenings, prostate cancer in particular, nobody wants a digital rectal exam. Right. But most of the guys that come in, they're worried about their prostate because they're getting up 2 or 3 times a night to urinate. Absolutely. Or they find that when they go to urinate, they go back to their desk and they think, I have to go urinate again. They haven't emptied their bladder completely. So the first thing they think of is prostate cancer. And I find a lot of the reason for me to do a digital rectal exam is actually to kind of offer them some assurance that your PSA is very, very low. Your prostate is not very big. You need to drink less caffeine or cut down your coffee intake. And so those are the kind of reasons that I do the digital rectal exam. But the PSA, it's a question of what you do with information.
Absolutely.
And so you can live in oblivion and not know what your PSA is and have no prostate cancer until it's too late.
Live for a while.
Exactly. Right. Sure. Live for a while until it's too late. But if having a PSA done every year, it gives you the ability to make an intelligent decision. Mm-hmm. You don't have to reflexively take out your prostate or go have a biopsy if it moves up a little bit, but you can then follow it and not be caught by a surprise.
PSA got a bad rap. It really did. It really did. And that's almost like saying screwdrivers are bad. Yeah, you can break a window with a screwdriver. Yeah. It's not the screwdriver that's the problem. It's how you use it. And we did for years. I'll definitely say we misused it. Mm-hmm. It was misused. It was used to screen every man over 85, 90. We misused the test. Mm-hmm. But now that we've figured it out and we're using it appropriately, we need to get this to come and shift back.
And there's no perfect test.
Right.
You can, in the wrong hands, you can misuse any tool.
Absolutely.
But it's the test we have. And so until a better test comes along, which I have not seen one, the PSA is a simple blood test. There's no, there should be no cost on an annual basis. It should be part of your insurance benefits, and it's a very, very unfortunate thing to see a late stage prostate cancer in a young man.
Fascinating conversation about men's health. We're talking about both the physical and mental part of it. Hope you'll continue to stay with us. You're watching inStudio on WSRE Television, PBS for the Gulf Coast. We're coming back in just a few moments. Hope you will too.
You're watching viewer-supported WSRE TV, a service of Pensacola State College.
Welcome back. This is inStudio on WSRE Television, PBS for the Gulf Coast. Our topic, men's health. Our guest, urologist Dr. Brett Para with Woodlands Medical Specialist, dermatologist Dr. Kevin Welch with Welch Skin Care Center, psychologist Dr. Rick Spencer with Psychological Associates, and primary care and internal medicine specialist Dr. Mark Ryan with the Woodlands Medical Specialist. Dr. Welch, we were talking in break about taking care of our skin, and I want to talk about some of the cosmetic stuff as well, but what should you do if you see something that you're not 100% sure? How do I know, well, that's just a freckle or it's something I should be concerned about?
It's not possible to really know for sure. And even when people come into the office, we often can't tell for sure. Now we have our suspicions, but a biopsy is going to give you pretty definitive information. But for the most part, if you come to see a dermatologist, we'll be able to tell you 90% of the time without even doing a biopsy, that's okay, that's not okay. Probably the single most common thing I see people come in for are seborrheic keratoses, age spots. And you get a raised brown scaly spot, and people worry about it because they can feel it, they can see it. I remember I was taking a shower. I got my first one at 35, so I got my first old age spot at 35, and I was like, I was mortified, but you can feel it, and so it bugs people, and it bugs guys, or they're visible on the face. And in general, if it's raised and brown and scaly, in general, it's okay. Melanomas, which are the bad kind of skin cancer, tend to be flat. They tend to be just a smooth, funny-looking mole. The old ugly duckling thing. It looks different than all the other ducks. It's darker, bigger, weird shapes, irregular borders. But basically, if something's new and changing, it really behooves you to get it checked out.
When you say changing, how quickly should you pay attention to how it's changing?
Fast enough that you notice it. And what I mean by that is, we see people come in and they'll say, "Oh, that's been there my whole life," and you know it's only been there a few years. But changing means when people notice changing, it's really within a matter of a couple months. They see something go from the size of the tip of your pen to twice that size, and they notice it. It's in a place where they can see. Now their back or back of their legs and things, they don't see those areas. But in areas where you can see, you notice a mole getting bigger, something creeping out. Those are the sort of things you really need to pay attention to. Let me add, sorry to interrupt, one more thing, bleeding. People, I wash my face and this spot bleeds, and that's probably more like a basal cell skin cancer. But that's a very, very common thing. And if anybody in the audience is having an experience where they wash their face or they scratch something and it recurrently bleeds, they should get it checked out, because that 9 out of 10 times is a little skin cancer.
Just talking about preventative approaches, from a skin cancer standpoint, how often should we go in to see a guy like you?
It's a little bit like the prostate situation, where if there's a strong family history of melanoma, you probably should come in once a year. If there's not much of a family history and you're African American, you probably don't need to come in very often. African American skin, black skin, is just so much better protected from sun. If you're a light-skinned Irish person, you probably should come in once a year after the age of 45, 50 or so. And once you do have a skin cancer, you definitely should come in once a year, because the most predictive thing about having a skin cancer is having a prior skin cancer. And
what is the best way to protect yourself? Sunscreen? I mean, that's what we hear, is that...
Go to the beach at night. but sunscreen, at least an SPF 30. Reapply it. You probably should put sunscreen on every 2 hours or so. I'm as guilty of this as some. So my daughter had a lacrosse game this past weekend, lacrosse half day on Saturday. She comes home and says, "Boy, Dad, I'm sunburned." And I'm like, cover my head up, because I didn't adequately instruct her about putting sunscreen on. And you want to instruct your kids, at least, do better for your kids than you do for yourself, because most of the sun damage is happening when you're a youth, not when you get older. Because when you get older, we get a little bit smarter, we're more careful with hats and sunscreen, but you really need to apply it every couple hours. Some people, come in, "Oh, I bought this really good sunscreen," and they have the same bottle of sunscreen they use all year, because they use it 3 times a year and use that much of it. And really what you need to do in a place like Pensacola is apply sunscreen every day, including wintertime. It was 30 degrees recently. You still need it. Every day, 365 days a year, with exposed sites. You drive around, it's sunny. We got 300 days of sun. Sun, car, sun walking, even little stuff. You have 5 minutes here, 5 minutes there. By the end of the day, you've had an hour of sun. 6, 7 days a week, you've got 5, 6 hours of sun, just like going to the beach. So daily sunscreen application, at least an SPF 30, and if you're outside, reapplication every 2-3 hours.
Now, we were talking also about cosmetic surgery and cosmetic dermatology. You said you're starting to see more and more men come in for that?
More and more men are coming out. The world is changing, and men are developing an interest in looking good. And I think a lot of younger men, particularly, sort of that.
Millennials.
The millennials. There's some of my millennial patients, they are very concerned about their appearance, and not inappropriately so. They just have a different mindset and take more care of their diet, their health. They actually are more inclined, I think, sometimes to even pay attention to things they should pay attention to medically. But they're very concerned about their appearance. And the other thing I point out is if you look at pictures of CEOs from 50 years ago, they all had brown spots, glasses, and bad teeth. You look at pictures of CEOs now, man, they look like you guys. You know? You know? And so men are coming in now. They don't want some of those obvious signs of aging where they have brown spots on their face or you know, they can do a little this, a little that. Again, it's often driven by their female partner or sometimes their male partner because they want to look good and their partner is also encouraging them to take some, you know, simple sort of steps to look better.
Give me a couple ideas on the simple steps to look better. What can somebody do?
Botox is very easy. You know, sometimes people have concepts about Botox being dangerous or difficult or poisonous and all this stuff. The problem with Botox is once most people try it, they like it and want to keep doing it because it's not real obvious. It just relaxes your skin, makes it look a little smoother. And then simple lasers to take brown spots off. Brown spots really age a person's face. If you think about it, you look at somebody and you can tell in half a second in your mind approximately how old that person is. And think of all the computations you do to make that decision. One of the computations that comes into play is how much pigment they have in their face. People with a lot of pigment are older than people that don't have much pigment. You know, 20-year-old kids, pretty smooth, even colored skin. 80-year-old people, blotchy, brown, and there's a transition. So if you can even out your skin tone get brown spots off there, maybe smooth it, a little Botox, simple, inexpensive, less than $500 type things that you can do to just make yourself look a little better without anyone knowing about it.
Interesting, very interesting. Dr. Ryan, when someone comes in to you, let's just say the first time, what are you focusing on? If it's a new patient and doesn't seem to have any real medical issues, what are you focusing on in order to set the stage that this person continues to live a healthy life?
Sure. I think, so with men in particular, if they come in for just a wellness visit, I want to kind of make sure they know the biggest risk to their health. And so just kind of we kind of talk about any acute problems they have, but then kind of going into preventive discussion, it's kind of laying out the biggest risk to their mortality, their death. And I tell men and women that the number one cause of death in America is still heart disease, so heart attack, stroke, and then the second, and actually in some states, cancer has overtaken cardiovascular disease as a cause of death. And that really, in the past 2 to 3 years, that's occurred. Still within Florida, it's cardiovascular disease first. And I tell them that. And I think that you need to know what the risk factors are for developing heart disease or having a stroke in your lifetime. And the number one thing is your blood pressure. And so the blood pressure targets, there was a really well done clinical trial that was actually had to be stopped after 2 years. It's called the SPRINT trial. And in that trial, they looked at men and women who were at risk for heart disease, and that just means they were above the age of 50. So they took 10,000 men and women above the age of 50 and grouped them into 2 categories. In one category, they had blood pressure targets of less than 140 over 90. And in the second group, they had a blood pressure target of less than 120 over 90. And they had to stop the trial after 2 years because the group who had a blood pressure of just 20 points lower had decreased the risk of heart attack and stroke by 40%. And that's in 2 years. And the researchers thought, wow, that is such a profound finding. Yeah. We feel bad and we feel guilty that the people who have higher blood pressure, we can't let them go on like that. And so I think that in talking with men in particular, initially in the first conversation and kind of stressing the importance of knowing what your blood pressure is and knowing what normal is. And then beyond that, kind of how you can keep your blood pressure normal, because that is the real big target. And really it comes down to walking. You know, the most common thing I hear is I just don't have the time to exercise. And I bought a membership to a gym and I waste $50 every month because it just sits there and it's on a cycle. And I tell men, listen, I'm not probably as busy as most of the guys at the table are, but I have a wife, I have children, I've got responsibilities, I have to go to work every day, and you don't need a gym membership to walk around the block. So put on your suit and tie, put on your shoes, and walk around the block. And that's 15 minutes, do that twice a day. That's the exercise you need. You don't need to join a gym, you don't need to run a 5K, you just need to walk on a consistent basis, and that will bring the blood pressure down. So those are the kind of the things I stress initially. And then depending on the body shape and the weight, we talk about dietary changes. But I think those are the big things I talk about are blood pressure targets and kind of maintaining an active lifestyle. And I think anybody at the table knows if you know somebody who's 85 years old, and you have kind of your goal of who you want to be as we go forward, and I think to a person, if you maintain an active lifestyle throughout your adult lifetime, you will arrive to your whatever old age is for you in a very good position. And I think, and this is the time as we kind of look around the table here, fighting to maintain an active lifestyle, doing whatever it takes in terms of seeing an orthopedist or really kind of fighting to maintain activity is a very, very important thing for health going forward.
And I think the interesting thing you're saying is you don't have to go out there and run the 5K. I mean, it's just the little things cumulatively over time, right?
And within the confines of whatever disability or whatever kind of physical constraint you have, if you have bad knees or a bad back, maybe it's not walking, maybe it's getting on a bicycle or getting into a pool and doing a routine. So I try to make it as simple as possible for patients, because that's really what it is. It doesn't have to be anything complex. In fact, the simpler your activity regimen is, the more likely you are to do it and the more likely you are to enjoy it going forward.
I hear a lot of talk these days, particularly as we get older, that strength training should be a big part of our exercise regimen.
Sure. Yeah, and I think it depends on what your goals are for your activity. And so I think for me, I tell patients that my prejudice is I don't want you to have a heart attack or a stroke. And so we start from there and then we branch out. Okay. And so the walking, at least 15 minutes twice a day, will decrease your risk of heart attack and stroke. Strength training is very, very important, I think, for a number of reasons. And we talk about a lot of men that come in, they're worried about their testosterone levels.
Oh gosh.
Yeah. And so, you talk about ways to.
That's huge.
Yeah. And I think that's
more
probably
of a psychological issue, I think, than anything else, because our testosterone levels just naturally go down.
Yeah. I agree.
Andropause.
Yeah.
And so I think, and I think that there's so much, and I tell men when they ask me to check their testosterone level, and I ask them, well, what symptoms do you have that you can attribute to a low testosterone? Because anybody, when you look at a sheet of paper and you see your testosterone level is lower than the normal range, you automatically have every symptom that you can think of from low testosterone. So you may have started off you may have come into the exam and said, I have no sexual problems, I have all the energy in the world, I've got all the confidence in the world. And then, you show this number and they say, oh my gosh.
I do have a little of that.
I need testosterone.
I'm kind of tired right now.
So I think to your point about strength training is well taken. And I think that there are some ways that you can naturally boost your testosterone, and strength training is a big part of it. But I don't, that comes down to an individual basis. But yeah, definitely kind of strengthening your upper torso is a good part.
I think that even though I think younger America has certainly embraced exercise and health way more than we did probably in our generation. I know my daughter gets on to me about my health all the time, talks about the grain brain and so forth. But we also have so many still health risk behaviors that are still a concern we have to deal with. Smoking, too much alcohol, obviously overeating. And in my experience, the folks that have been long-term smokers or long-term alcoholics, they only really will stop if there's a major cost. They find out that, oh my God, I've got stage 4 liver disease. Maybe I have a cancer or I have emphysema. And so those calls finally get these people to make some changes. We got to find a way to get people to stop those things before that point, getting back to prevention.
I also want to talk about something that I hear is a major detriment to your health, and that's stress. I want to talk to you when we come back about the best way to deal with that. We will continue, I shall say, our discussion on men's health in just a couple of moments. Hope you'll stick around and stay with us. This is inStudio on WSRE Television, PBS for the Gulf Coast. Back in a couple of moments.
There are over 42,000 children under the age of 5 in Northwest Florida. Many of these children will never have the opportunity to go to preschool. Thanks to quality educational television programs and WSRE's Imagination Station, these kids are developing critical early learning skills. Any decrease in funding will impact our ability to deliver PBS Kids programs like Wild Kratts, Daniel Tiger, and the Art Squad. These programs introduce children to science and nature, teach them about the world, and show them that learning can be fun. Most importantly, they connect with children and share a message about caring, friendship, and individuality. In the immortal words of Mr. Rogers, there is no person, in the whole wide world like you. And I like you just the way you are. There's no other place in the whole wide world like PBS Kids. If you like us just the way we are, please call in with your donation today and say to all, I love WSRE. Thank you.
This is In Studio on WSRE Television, PBS for the Gulf Coast. We are discussing men's health with doctors Kevin Welch, Mark Ryan, Rick Spencer, and Brett Para. Dr. Spencer, we live in a stressful world. How's the best way to manage that?
Well, I think first, stress is just a part of being human. You know, anything we do that's uncertain or any change we make that has some ambiguous outcome, it's going to be stressful. So anxiety can be a part of that. But in reality, as you know, everyone is trying to figure out how to reduce our stress. There are thousands of self-help books and ideas out there. But in reality, what we need to do is get back to hypertension, breathe, slow down, find ways to relax. It could be simply walking your dog, having a nice stroll with your wife. But other ways are more direct. Some people preach 10-minute relaxation exercises or 10-minute periods of meditation. These days, the buzzword is mindfulness. Mindfulness is a concept of being able to allow yourself to feel what you feel and not judge the thoughts that are coming towards you and just kind of not get overwhelmed with it. I think a lot of us, when we start to be stressed, we start thinking, those thoughts, I'll call it, get into a loop. And it could be you're anxious or it could be you're angry, and that loop goes on. And you got to find a way to get out of it. Sometimes it's simply to divert yourself. I tell people sometimes to just see if they can actively divert themselves and try to think about what they're grateful for. It's something almost diametrically opposed. And then you start feeling a little bit different. You actually create your own level of serotonin in your body, which of course relates to positive mood, and it kind of helps you in the moment. But we all have to find ways to just relax, find balance in our life. We haven't really talked much about that. You did in the very beginning. But you know, work-family balance, work-leisure balance, all of that's something we need to always focus on. And as we get older and we think about retirement, there needs to be balance there too. We find that most retirees that actually still work a little bit actually fare better and are physically better.
Well, that's all too hard. I want a pill for that. I mean, we're a pill-driven society. I mean, I see it all the time. A guy will come in and they want a pill to fix everything. They want medicines. They want testosterone. They want, Viagra, whatever it is. I mean, when you sit there and tell them that, well, instead of getting a pill to slow your bladder down, why don't you just cut out the caffeine? Oh, no, I don't want to do that. You take the cigarette out, you put it kind of next to their area, and you say, hey, you get to keep one for life. Well, they don't want to hear that. We're a pill-driven society.
But then you look at all the possible ramifications of taking the pill.
But how about you take one pill to offset the side effects of another pill? We see it all the time. All the time.
I think that's absolutely right. How does someone within themselves go, wow, I'm at a point in life where maybe stress or whatever is overwhelming me, and I'm to the point where I can't necessarily take some of the advice that you just gave us about meditation and things like that. How do you know when maybe it's time to see somebody?
Well, I think you first recognize that most people that are trying to continue churning and they're stressed, they're not paying attention to it. And if we ignore it for a significant period of time, then you're actually at risk for a panic attack. So a panic attack happens and suddenly everything begins to just swirl and you go down and your heart begins to beat fast, you become dizzy, all kinds of physical symptoms, and you think you're having a heart attack. And you end up going to the emergency room and they say, no, well, you're just having a panic attack. And they tell you it's all in your head, and they freak out a little bit about that.
Right.
But that can be a consequence of just not paying attention to the signs. Your body always gives you signs of illness, right? All the symptoms, although obviously not the prostate cancer, but most of them give some kind of sign. Anxiety is a sign too. Stress is a sign that you need to do something. And that's, I guess, the best way to look at it is just observe your body.
Interesting. Going back to the whole exercise routine, why do you think people are so adverse to doing that? I mean, the research is solid.
I guess I don't. Most people, if you ask them, I routinely ask people what you're doing for exercise.
I don't have time for that.
Well, either that or everybody, and they always say something. You know, they always say, well, I'm active. You know, at my job, I walk all the time, I'm on my feet all the time. So I think no one says that I don't want, I take that back. There are very few, they're usually very colorful people who to tell you that. I don't exercise. I don't want to do any of that. You know, I sit at home and I watch TV all day long. Yeah, I don't exercise. I think that it really comes down to, I think, prioritizing things in your life. And I think as men, we tend to we get pulled in a lot of directions, and we, as we kind of tend to assume the role of kind of taking care of everybody else and making sure that the house is in order, that the children's school are paid for, that the wife has everything she needs, and you don't, I think of it in terms of a budget. You have line items in a budget where you pay your light bill, your electricity bill, your thing, but you don't budget time for yourself. And so I tell men, you need to take care of yourself. You need to carve out 15 minutes every day where you meditate, or you get down and you stretch out your back muscles, or you walk, and it needs to be something that it's just part of your routine. You don't go into your job and not do what the boss tells you.
Right.
So you need to actually kind of make that part of your daily routine. I think that's where it comes down into just ultimately taking care of yourself and prioritizing your well-being. I think we could say the same thing about that you look at, and I don't want to get too far off topic, but saving patterns. How people save money, and I think one of the first lessons I learned when I was kind of becoming financially smart is you need to pay yourself first.
Absolutely.
And so when you get a paycheck, you need to put 10% of that or 15% of that into a savings account and pay yourself first, and then everybody else comes after that. So I think the same thing in terms of exercise and diet, and you need to take care of yourself first so that you can be around to take care of everybody else around you.
One of the other things about exercise, I think, and also just appearance in general, is that people are driven a lot by social pressures in terms of looking attractive. And I'm sure all of us have friends, or and I see it all the time. Someone is about to get divorced. See, men and women, all of a sudden they come in, they lose 20 pounds, they're in there getting stuff done because all of a sudden they're back in the dating world and they want to look good. The converse of that is you get married, you're comfortable, you perhaps aren't quite as conscientious about keeping your appearance up because you have a steady spouse that cares about you and isn't caring about you just because of your physical needs. And I think a lot of men let themselves go a little bit because, hey, I'm married, I got a wife, and I'm not endorsing it at all, but you certainly see it happen.
Yeah, valid point. I have about 5 minutes left in the program. I'm going to go around the table here and have each one of you just sort of give me your take on what men should concentrate on as far as in relation to your area of expertise, what to watch out for, what to be aware of. I'll start with you, Dr. Parra.
Well, I mean, the big thing is just overall health. And for men, younger men, self-examinations. I mean, how hard is it in the shower to check yourself? I mean, that's what we should be doing. Women do it. We should do it. Any signs, symptoms of urinary symptoms, things changing, absolutely do it. Basically, anything that's good for your heart is going to be good for your sexual health, because when your heart pumps well, everything else works better. And the other thing is, when you get the chance and you reach those levels of life where you should consider screening, go for it. Get screened. Doesn't mean you have to get treated, doesn't mean you need aggressive therapy. It means you're just getting things checked out.
Dr. Welch?
I think in terms of skin, self-examination, again, and men and women can do it. And you can examine, probably 2/3 of your body without trying really hard. And it makes sense to look at it and know if a spot is new or different. Sometimes I ask people, is that new? I don't know, I never look, You look at the places you can look. And then, as I sort of mentioned earlier, if you have a spot that bleeds when you wash it or something like that, go in and get it checked. Because most times, your skin shouldn't be bleeding. If your skin's bleeding, there's probably something wrong.
Dr. Spencer?
Well, I would probably say that, try to challenge the stigma of mental health. If you're feeling depressed and you don't know why, you're feeling angry, it's okay. I mean, counselors are just like you. and they're not scary people.
Right.
We're pretty low key and easy to talk to.
Right.
So try to lessen the threat and recognize that your mental health is just as important as your physical health, and they both integrate completely.
Right. A couple of minutes, Dr. Ryan.
I think there used to be a campaign probably about 10 years ago. It's called Know Your Numbers, and it was a big intervention into trying to get people to become more literate about their own health. And the numbers, so in that kind of same sense, I want people when they leave my office to know the basic numbers of their health. You should know your blood pressure, at least kind of what a normal blood pressure is for you, and then what your most recent blood pressure was. You should know your cholesterol numbers, in particular the LDL cholesterol, which is kind of the bad cholesterol. You should know your average blood sugar. Okay, so a normal blood sugar is less than 100. You should know if you are above or below that. And then the last thing is your waist size. And I think that's something that we don't necessarily talk about all the time, but a normal waist size in a man is below 36. And so that is a really that's a strong indicator of declining, or risk to your health going forward. If your waist size is above 36, you are at very, very high risk for diabetes, poorly controlled blood pressure, poorly controlled cholesterol, and all of those combine to make you a very, very high risk for heart disease. And so knowing, again, blood pressure, cholesterol, blood sugar, and your waist size, and working toward making or optimizing those numbers is a very, very easy thing to do. And it should be part of any, not even an annual physical, but any office visit, certainly to an internist or a primary care physician. That should be part of what you're experiencing.
One of the things that we did not get to talk about, which I know is, I guess, if it's not an epidemic, it's certainly close to it, is diabetes, right?
Sure.
Type 2 diabetes. So in about 45 seconds, what should people be on the lookout for as far as that's concerned?
Well, so signs of diabetes would be if you're extremely thirsty, if you're urinating all the time, if you're very lethargic, that is probably, you should be going to a doctor kind of right about now. But in general, those four numbers, blood pressure, blood sugar, cholesterol, and waist size, if you can keep those in a normal range, you should not really have to worry about type 2 diabetes going forward.
Very good, very good. Gentlemen, thank you. Very, very informative. I enjoyed it, and hopefully our audience did as well. We've been discussing men's health and how to keep ourselves in top mental and physical condition. Our guests have been primary care and internal medicine specialist, Dr. Mark Ryan. He is with the Woodlands Medical Center. Also a psychologist, Dr. Rick Spencer from Psychological Associates. Dermatologist, Dr. Kevin Welch with Welch Skin Care Center. And urologist, Dr. Brett Para with Woodlands Medical Specialist as well. By the way, this program will be available online at WSRE.org. We're also going to put it on YouTube, and perhaps it'll be flying around Facebook as well. We certainly encourage you to feel free to share this program. Hopefully a lot of good information that may be helpful to an awful lot of people. I'm Jeff Weeks. Thank you so very much for watching. I hope you enjoyed the broadcast. Take great care of yourself. We'll see you soon.